Good day everyone. I welcome you all to the lecture on Introduction to Bone Tumors. The aim of this lecture is to learn about the different tumor types, with regard to its tissue of origin, the age of the patient, and the location in the bone, whether it is epiphyseal, metaphyseal, or diaphyseal. Further, we will learn about the basic approach to the tumors, and understand the importance of margins, or the zone of transition, used in tumors. Before we proceed with the types of tumor, and details about each, let us get some basic facts in place. Firstly, bone tumors are rare. Benign bone tumors are far more common than malignant tumors. Primary malignant tumors constitute only 1% of all cancer. There is an age predilection for certain tumors. Classification is based purely on the tissue of origin. As we can see here, the benign and malignant bone tumors are classified on their tissue of origin. Benign osteoblastoma and malignant osteosarcoma arise from osteogenic tissue. Chondrogenic cells give rise to benign enchondroma and chondroblastoma, and the malignant chondrosarcoma. Fibrohistiocytic tumors include the benign fibrous histiocytoma and malignant fibrous histiocytoma. Benign hemangioma and malignant hemangioendothelioma and angiosarcoma arise from vascular tissue. Benign desmoid tumor and malignant fibrosarcoma are from fibroblastic tissue. Tumors arising from hematolymphoid and notochordal tissue are always malignant in nature. Lymphoma and myeloma arise from the former, while chordoma arises from the latter. Benign giant cell tumor and malignant Ewing's sarcoma and admantinoma are of unknown etiology. Some other tumors, like unicameral bone cyst, aneurysmal bone cyst, fibrous dysplasia, osteofibrous dysplasia, and Langerhans cell histiocytosis, are of undefined neoplastic nature. This slide depicts the relationship between bone tumors and age. It is evident from the chart that most benign bone tumors are seen in childhood and the young. Benign bone tumors, like infection, osteochondroma, osteoid osteoma, fibrous cortical dysplasia, non-ossifying fibroma, unicameral bone cyst, aneurysmal bone cyst, and malignant Ewing's sarcoma, are seen up to 20 years of age. Benign histiocytosis and malignant metastatic neuroblastoma, on Wilms tumor, are seen in children up to 10 years of age. Chondroblastoma and osteosarcoma are prevalent from 10 to 20 years of age. Giant cell tumor is seen from 20 to 40 years of age, while metastases, myeloma, and chondrosarcoma are seen in adults over 40 years of age. Malignant tumors are rare in young adults from 20 to 40 years of age, while benign ones are rare after 40 years. This is a good example to understand the importance of age and its relation to bone tumors. Look carefully at these X-rays. Both the radiographs show a well-defined lytic lesion in the metadiaphyseal region of long bones. The first radiograph is of a 5-year-old child, and the second belongs to a 64-year-old. The diagnosis in this case is a benign unicameral bone cyst in a 5-year-old child, and a metastatic lesion in the 64-year-old. There are some favored sites for certain tumors, as shown in this table. This information is very useful for differential diagnosis. For example, a lytic lesion in tibia of a 40-year-old is likely to be an adamantinoma. Flat bones, scapula, and pelvis are common sites for Ewing's tumor. Chondroblastomas and giant cell tumors are epiphyseal. The latter is typically seen in the distal radius. Fibrous cortical defect and osteofibrous dysplasia are cortical, non-ossifying fibroma, and chondromyxoid fibroma are eccentric and metaphyseal. Chondrosarcoma is commonly seen in the pelvis, chordoma in the sacrum and high cervical spine, and in chondroma in the small bones of the hands and feet. Combining the age, site, and characteristic features, the differential diagnosis can be narrowed. This is shown in the examples in the following slides. A cortical lesion in the femur or tibia, picked up incidentally, in the 10 to 20-year-old is likely to be a fibrous cortical defect. A cortical lesion in the anterior tibia in a 10 to 20-year child is most likely an osteofibrous dysplasia. A lytic lesion in distal radius in a 30 to 40-year-old is most likely a giant cell tumor. A lytic lesion in the femur or humerus in someone over 60 years of age is likely to be metastasis or myeloma. A lytic lesion with speckled calcification in small bones of the hand is an enchondroma. Have a look at these X-rays. The radiographs show the characteristic lesions. The first X-ray shows a lytic lesion with speckled calcifications in the hand. This is characteristic of an enchondroma. A lytic lesion in the distal radius is typical of a giant cell tumor, as evident from the second radiograph. The third X-ray shows the characteristic radiological appearance of an osteoid osteoma. Primary bone tumors are very rarely multifocal. There are a few exceptions to this. Osteochondromas, enchondromas, brown tumors, fibrous dysplasia, metastases, and myeloma can be seen in multiple locations. The image depicts the margins of resection for bone tumors. Depending on the nature of the tumor, there can be intralesional, marginal, wide, and radical excision. We shall learn more about these in the subsequent slides. In intralesional excision, the tumor is removed by entering into the substance. A curettage of a benign tumor is an example. The tumor is scraped with curettes. Typically, this leaves behind microscopic tumor in the wall. This method is most popularly used for benign tumors. There is a zone between the tumor and the normal tissue, which consists of loose areolar tissue and blood vessels. This zone may contain extensions of malignant tumor. Resection through this zone is called marginal resection. This method is adequate for low-grade malignant or benign tumors. In wide margin excision, the tumor is removed with a thickness of normal tissue. There are certain basic characteristics of this method. These are very important in wide margin excision. The tumor should not be visualized in excision. The margins are planned on MRI prior to surgery. It is mandatory that the excised part have 3 centimeters of bone margin, or a belly of muscle, or a thick barrier, like growth plate, or joint cartilage, or intermuscular septum. These are considered adequate, wide margin. This is the margin of excision, used for malignant tumors. In radical margin excision, the entire compartment is removed for tumor clearance. This is generally too much, and rarely used. Wide margins generally give an adequate tumor clearance. Certain basic principles are to be followed prior to excision of a tumor. A proper workup, including imaging and biopsy, should be done prior to treatment. Irrespective of imaging findings, biopsy is done to confirm the diagnosis. Osteoid osteoma and osteochondroma being rare exceptions, where biopsy is not required. Important points from the radiographic point to be considered are that certain malignant tumors can look benign on X-rays, and tumors can mimic infection radiologically. Tumors are known to mimic infection on X-rays. A classic example is this case. This was an 11-year-old boy who presented with acute pain, swelling, and fever. The X-ray appearance mimicked infection. Based on just the X-ray, the surgeon assumed it to be osteomyelitis, and debrided the bone. However, the final pathology revealed a Ewing's sarcoma. Debridement had led to extensive contamination of the tissues, and eventually, the limb had to be amputated. Hence always follow the golden rule. Biopsy before surgery is a must. Had the treating surgeon exercised more caution, the limb of the boy would be salvaged. Let us summarize the basic facts related to bone tumors. Tumors are classified based on the cell of origin. Many tumors have predilection to involve certain bones, or certain specific sites in the bone. Tumors have age-dependent presentation. Imaging and biopsy are an absolute must before surgery. Margin used in surgery depends on nature of the tumor. Suggestions for reading and reference. Thank you for your patience.